Very good evening to all listeners. On this evening, we shall be having a very good discussion on diabetes in pregnancy, regarding its pathophysiology and management of diabetes in pregnancy. And we are having Dr. Adrian Vella for that. He is professor of the medicine and having a lot of accolades in his career. He is having professor of medicine at the Mayo Clinic College of the Medicine and has been on the staff of Mayo Clinic, Rochester since June 2001. So over to Dr. Adrian Vella without taking much time.
Thank you for having me. I'll go ahead and start by sharing my screen. We can go ahead and get started. So I was asked to speak about the pathophysiology and management of diabetes in pregnancy. These are my disclosures. Today, what I intend to do is I'll talk about the nuances of diabetes in pregnancy, pre-existing diabetes or diabetes discovered during pregnancy versus gestational diabetes, and then talk about the pathogenesis of diabetes and the effects of pregnancy on the pathophysiology of diabetes, as well as the rationale for management. We'll talk about outcomes and complications associated with gestational diabetes and speak a little bit about management at the end of this. So usually it is straightforward to distinguish between pre-existing diabetes and gestational diabetes. The management, at least the goals of management, overlap adequately. At the end of the day, it is all about adjusting therapy to the appropriate glycemic targets for pregnancy and ensuring that we avoid hypoglycemia and other complications associated with pregnancy. With pre-existing diabetes, especially long-standing type 1 diabetes, we have to consider microvascular complications and the possibility that these might worsen during pregnancy, things like retinopathy, which can progress, and nephropathy, which might have implications for fetal growth and development during pregnancy. Ideally, in these situations, the secret is to actually plan appropriately and have management plans in place before conception, but that is not always the case, and sometimes people show up 3 months pregnant with A1Cs of 10% and a history of proliferative retinopathy, which will need to be managed on a case-by-case basis. Gestational diabetes could also be a presentation of established type 2 diabetes. It just so happens that pregnancy is what brought people in for a medical examination. And there's also a possibility that type 1 diabetes is presenting as gestational diabetes for the first time. Both of these scenarios have significant implications for management and follow-up after delivery. It's also important to appreciate that GDM is the strongest risk factor for future type 2 diabetes. An interesting statistic to consider is that about 50% of women with gestational diabetes will develop diabetes within 10 years of delivery. The thing, though, is it's interesting because gestational diabetes likely represents an early failure of the beta cell. We'll talk about that in just a bit. But it's also interesting to consider that fully half of people with gestational diabetes essentially return to normal and stay normal. And that heterogeneity is interesting from a pathophysiology point of view, which we don't necessarily understand at this point in time. But that will require further work. So here I'm going to quote my mentor, Dr. Robert Rizza, about the defects in type 2 diabetes. And when Bob was always asked to define type 2 diabetes, he would always answer by showing this slide. So essentially, it's important to remember that people who are not diabetic have what we would consider to be normal fasting glucose and a relatively contained postprandial glucose excursion, so that by 120 minutes, they have returned back to their fasting baseline. In contrast, people with type 2 diabetes have a higher fasting glucose. Their blood sugars go a lot higher in response to meal ingestion and stay higher for a lot longer. In fact, it takes them close to 5 hours to return to their baseline. And this is because despite having higher fasting insulin concentrations, which are clearly inappropriate for the fasting glucose concentrations, their insulin secretory response is actually delayed and decreased compared to non-diabetic individuals. This relative deficit in insulin secretion is actually compounded by the lack of suppression of glucagon. And in fact, some people with diabetes have a paradoxical rise in glucagon concentrations in response to meal ingestion. So clearly, type 2 diabetes is a bihormonal disease, at the very least, in the sense that there are defects in both insulin and glucagon. And as we shall see, both are important in the pathogenesis and pathophysiology of diabetes. So I was trained to think that there are 5 physiologic parameters that we have to consider when considering the abnormalities of postprandial glucose concentrations. And all of these are extant in both type 2 diabetes and in gestational diabetes. The most important consideration, as I've already shown you, is insulin secretion. So insulin is secreted into the portal circulation. The only other factor that affects insulin secretion directly is hepatic extraction, because as insulin travels across the hepatic circulation, in health, about 50% of it is extracted. It is unclear as to whether this is a passive process or an active process. We do know that the amount of insulin secretion can actually modulate hepatic extraction. So in fact, as insulin secretion falls in diabetes and pre-diabetes, hepatic extraction decreases. In a way, it might represent an adaptation to allow insulin into the systemic circulation, perhaps to counteract hepatic insulin action, which is decreasing in type 2 diabetes. So insulin action, which is the inverse of insulin action, is insulin resistance, okay? But if we defined it from a physiologic point of view, we'd say that insulin action represents the ability of insulin to stimulate glucose uptake and suppress glucose production. And again, this is something that is impaired in people with type 2 diabetes and in people with gestational diabetes. Glucagon suppression is the third factor, if you will, that affects postprandial glucose concentrations. And I'll show you some data that directly implicates glucagon in postprandial hyperglycemia. And then there is another parameter which is also underappreciated, which is glucose effectiveness. And glucose effectiveness is the ability of glucose itself, rather than of insulin, to stimulate its own uptake and suppress its own production. So glucose, when it rises after a meal, will stimulate its own uptake into the periphery, into muscle, for example, into the liver to some extent, and suppress endogenous glucose production by the liver. And the final parameter to consider is gastric emptying, although that is not necessarily germane to the pathogenesis of diabetes per se, but directly affects postprandial glucose concentrations. Not particularly important in the pathophysiology of gestational diabetes either. So to take insulin action and insulin secretion in context, because I don't think you can separate them completely, I like to think of them in terms of the power to weight ratio of the beta cell. And I always use this example, so you'll have to forgive me here, but basically, Concorde has 4 engines, okay, and flies at the speed of sound. HMS Ark Royal has the same engines, the same number of engines, but it barely makes 30 miles per hour. So despite having the same power, the speed is different. The reason for that is obvious, okay? So if you keep that in mind, you consider that when you talk about insulin secretion for the beta cell, you also have to consider, if you will, the size of the rock that insulin is trying to move up the hill. And in fact, this concept is expressed as something called a disposition index. And the disposition index is the mathematical equivalent of this hyperbolic relationship between insulin sensitivity and insulin secretion. So this is actually an example from Tom Buchanan's work. I'm going to show you another example of. Tom actually worked with Richard Bergman, but Richard Bergman and my good friend Claudio Cobelli actually invented the oral minimal model and conceptualized this hyperbolic relationship between insulin secretion and insulin action. So the whole idea here is that if you are a normal individual living on this disposition index, if you become insulin resistant, you adapt by secreting more insulin. If you can secrete more insulin, you stay on this curve. If your beta cell cannot adapt to increasing insulin resistance, you fall off this curve and get onto a curve which is lower and to the left. Okay, so for example, in this individual, if you will, pregnancy caused an increase in insulin resistance, and because said individual was unable to produce enough insulin, they fall over and their disposition index decreases. So they live on this curve. After delivery, insulin resistance decreases, and obviously there can be a shift to the right, and you return back to your previous curve, and hyperglycemia resolves. In some people, it does not resolve. Okay. Now, Tom Buchanan actually harnessed this principle directly by treating people with a history of gestational diabetes postpartum with troglitazone, a PPAR gamma agonist, which now is no longer on the market. But the point is, he took people before treatment. Treatment decreased insulin resistance. Okay, so people moved to the right, and you can see the open circles here, with a consequent decrease in insulin secretion, and therefore what he called an unloading of the beta cell. He was able to show an improvement in glycemic control and an improvement in beta cell function subsequently. So this is a principle that underlies the pathophysiology of type 2 diabetes, which has clear relevance to the concept of gestational diabetes in this circumstance. I told you that impaired glucagon suppression is actually important. And in fact, this is an experiment that was being completed at the time that I joined Dr. Riza's lab by my good friend, Dr. Pankaj Shah. And Pankaj showed that even in normal, healthy people, I believe their average age was 28 and BMI was 24. If you gave them a normal insulin profile but failed to suppress glucagon, you actually had a small increase in peak and integrated glucose concentrations. However, if these people had a diabetic insulin secretion profile, the lack of suppression of glucagon caused very marked hyperglycemia compared to suppressed glucagon. And then glucose effectiveness. This was an experiment performed by my colleague, Dr. Andy Basu. And essentially the principle is that people have an individually determined insulin infusion, which maintains euglycemia in the presence of somatostatin, and then they're given a glucose bolus. And the time necessary to clear and the area under the curve for that glycemic excursion represents glucose effectiveness. And as you can see, people without diabetes had lower peak and integrated glucose concentrations, accompanied by increased glucose disappearance into the body, out of the circulation, and increased suppression of endogenous glucose production compared to people with diabetes. And finally, when we talk about gastric emptying, it's important to appreciate that the upper gastrointestinal tract, in part with the neuromuscular plexus that controls enteric motility, and in part with cranial nerve input via the vagal nerve and the autonomic nervous system, has a set of reflexes, which also include the secretion of various hormonal mediators, which are designed to limit food output by the stomach. So the stomach is churning food into chyme, which can pass the pylorus, and the caloric content of whatever passes through the pylorus stimulates a network of both mechanoreceptors and chemoreceptors, causes neural reflexes as well as secretion of hormones that all integrate to delay gastric emptying, so that caloric delivery to the upper intestine is relatively fixed after a meal. And what's actually interesting is that the rate at which the stomach empties its contents is influenced by caloric content. So if it's just water, it empties very quickly. 50% of stomach contents would be emptied in about 10 minutes, 10 to 15 minutes. But as you can see, as the caloric load of ingested food increases, then the half-life, the time necessary to empty 50% of contents, starts to increase progressively. So that if you have a high-fat meal, okay, the time taken to empty 50% of fat content is about 180 minutes, okay? An order of magnitude higher than it is for water or other liquids. So, pregnancy is an insulin-resistant state. So you're going to impair insulin action, which you can compensate for by increasing insulin secretion. If you cannot do that, hyperglycemia is going to result. And then there's this question as to how the beta cell adapts to impaired insulin action. Is there beta cell growth or the growth of new beta cells in pregnancy? Alpha cell function has not really been studied, but may play an important role, and we'll talk about that briefly in just a bit. And then there are numerous animal models which suggest that things like prolactin, which obviously its secretion is increased during pregnancy, growth hormone, and serotonin contribute to islet adaptation. All of these contentions come from rodent models, and I'll submit to you that rodent models, at least in terms of beta cell growth and replication, may not have a lot of relevance to humans, in the sense that there is no clear evidence that beta cells turn over in humans at any rate comparable to what is observed in rodents. And in fact, it's interesting to note that the genetics of gestational diabetes overlap almost completely with that of type 2 diabetes. And in fact, TCF7L2, which is the variant with the strongest effect on predisposition to diabetes, to type 2 diabetes, is also the variant with the strongest effect on risk of gestational diabetes. And it's interesting because TCF7L2 was described in March of 2006 as being associated with type 2 diabetes. And in a sense, it ushered in the modern era of genetics in type 2 diabetes. We actually used it as a probe to understand the pathogenesis of diabetes. And in fact, in non-diabetic individuals, we were able to show that people with 2 copies of the diabetes-associated allele had a different hyperbolic relationship between insulin action and insulin secretion compared to people with the diabetes protective allele. So you can see that at the lower ends of insulin resistance, they needed to be more insulin resistant to secrete the same amount of insulin as their CC counterparts, who are age, weight, and sex matched, by the way. What's also interesting actually is that when subjected to acute insulin resistance, you can see that both behaved equally badly in those situations. But the other interesting observation that we made, which was completely unexpected, was that TCF7L2 actually also impairs the suppression of glucagon. And this effect is most marked in people with impaired glucose tolerance. So TCF7L2 actually predisposes to type 2 diabetes and gestational diabetes 2 ways. It affects insulin secretion weakly, and it also affects the suppression of glucagon in the postprandial setting. So that's actually extremely relevant to the pathogenesis of type 2 diabetes. Obviously, the higher the BMI prior to pregnancy, the more likely the prevalence of gestational diabetes. So if you have a BMI between 30 and 35, there's a 5.5% prevalence of gestational diabetes. And if it's higher than 35, then the prevalence of gestational diabetes increases even further. Now, how do you make a diagnosis of gestational diabetes? There's a lot of controversy about the importance of postprandial glucose concentrations versus fasting glucose concentrations. I think it's important to appreciate that one does not arise independently of the other. So it's a question of choosing the right glycemic targets. And if you choose the right fasting target, it's as good as a postprandial target or cutoff for the diagnosis of diabetes. What's actually interesting is that, the IAPSG had actually suggested that glucose in the first trimester that is greater than 5.1 millimoles per liter could be diagnostic of gestational diabetes and would not require subsequent testing in the 24th to the 28th week of pregnancy. The problem was that this was rescinded because it was actually poorly predictive of glucose tolerance later. And that likely implies changes in glucose metabolism in early pregnancy versus the remainder of pregnancy. What's actually also important to appreciate is that cutoffs are actually somewhat arbitrary. And somebody who has, if, for example, we're taking a cutoff of 10 millimolars 1 hour after an OGTT, it's important to appreciate that people with a 9.8 millimolar value and people with a 10.1 millimolar value are being classified as completely different individuals, normal versus gestational diabetes, but biologically, they probably represent the same person. And so we are treating people differently based on an arbitrary continuum, which is glucose-based and subject to significant variability of its own in testing and retesting. So we have to keep that in mind. This is data from Gunther Boden, and I show it here. This is just euglycemic clamp data, just to show the differences in insulin resistance in the third trimester compared to the postpartum period. So this is the insulin secretion rate necessary to maintain the same degree of glycemia, both in the third trimester and postpartum. And you can see that there's at least a twofold increase in insulin secretion compared to the postpartum period. How is this achieved? Well, there's only one autopsy study in humans, for obvious reasons, that looked at beta cell size. And you can see, this was actually from the Mayo autopsy database. You can actually see that there was no evidence of beta cell replication, and there was no evidence of a change in beta cell apoptosis associated with pregnancy. What was actually interesting was that they showed an increase in beta cell area, i.e. the amount of insulin staining in a beta cell. And this is likely the adaptation that humans make to pregnancy. They increase the amount of insulin made per beta cell rather than necessarily increasing beta cell numbers, which is completely unlike rodent models, and hence why rodent models are likely not very relevant to the study of the human condition. As this audience knows, neonatal complications of hyperglycemia are typically things like macrosomia, neonatal hypoglycemia, and hyperinsulinemia. And as glycemic abnormality increases, the likelihood of these abnormalities, of these complications, increases. Same with fasting plasma glucose and large for gestational diabetes, large for gestational age, whose prevalence increases to 20% if fasting plasma glucose is consistently about 5.3 millimolar. In terms of pharmacotherapy, well, for pure gestational diabetes, lifestyle modification is the prime prime early therapy, and is the foundation on which any subsequent therapy is based. Over the years, there has been some tendency to use glyburide or other sulfonylureas and metformin as oral agents in the treatment of gestational diabetes. I think the American Diabetes Association and myself would firmly suggest that insulin is probably the medication that would be indicated, and the one that I certainly would be most comfortable using in these situations. There's a lack of long-term safety data with oral agents, and there's no clear evidence that treatment improves outcomes with oral agents. So I'll conclude by saying that islet cell function is the primary regulator of glucose metabolism in humans. Currently, there's a paucity of data as it applies to islet adaptation and expansion in humans during pregnancy. And certainly the evolution of gestational diabetes postpartum is understudied and ignored. How much of these abnormalities persist, accelerate, continue under prior decline? We don't really know that. We also don't know why 50% of people with gestational diabetes never go on to develop diabetes. We don't actually know if number of pregnancies, for example, increases your risk of type 2 diabetes very clearly. So there are some basic fundamental questions associated with gestational diabetes that we don't actually really know. I think management should be focused on glycemic control, and overall, I would tend to favor insulin therapy in these circumstances. So those were my conclusions. I'd like to acknowledge my study staff, my study subjects, my mentors over the years, and my colleagues at the University of Padova, who always have provided helpful advice and mathematical modeling for our data, for our studies. So thank you very much for listening to me. I'll stop here.
Thank you, Dr. Adrian Bala, for a nice, lucid presentation, and we really enjoyed and learned a lot about gestational diabetes. We many of the times have a temptation of using the oral medications in the pregnancy. Most of the time, most of the females are so young, or first time they are experiencing diabetes. So acceptability of the injection insulin is not so good. In that condition, if we, and some of the guidelines also recommend about the metformin uses in the pregnancy. What is your view, although you have given in your presentation that metformin crosses the placental barrier, but this amount of the metformin which crosses the placental barrier is really injurious for fetus, or something else is also there with metformin for which we should not use this?
No, so I don't think, I don't know that metformin would be injurious, and there isn't any clear data. My concern comes from the fact that studies that have looked for teratogenic effects are classically very underpowered to reliably detect a teratogenic effect of these medications. So we cannot say with certainty that they are not teratogenic. I mean, if we actually went so far as to split hairs, we would say that really the only insulins we should be using are regular insulin and NPH, because only those have been studied extensively enough that we know that they are not teratogenic. We use, at least in my practice, if somebody comes in with a prior history of using glargine insulin, for example, and they become pregnant while they're on glargine, I don't change insulin. Most of my colleagues do not change insulin. But strictly speaking, there isn't any data about teratogenicity with glargine like there is with NPH insulin. And the same applies with metformin. The better concern about metformin, so to speak, rather than teratogenicity, is the concern that there's been no convincing evidence that its use prevents fetal macrosomia more than anything else. The one thing that I neglected to say actually in the beginning is that most of the time fetal size is programmed within the first to the middle of the second trimester. And most of the time with gestational diabetes, we're screening at the 24th week and 28th week. And we're intervening to change glycemic control when already a significant amount of fetal size has already been determined and programmed. And in fact, that's a significant deficiency in how we manage gestational diabetes. I've already told you that in the first trimester, glucose is not really predictive of gestational diabetes in the third trimester. So we clearly need a better biomarker to be able to intervene therapeutically earlier. But we don't have it right now. And I don't think there's any harm associated with using metformin. There may not be as much efficacy as using metformin, is perhaps what I was trying to say.
Don't you agree with MIG studies results, which has recommended metformin can be used in the pregnancy?
Yeah, I mean, again, no harm is likely to be coming from them. Whether I would feel comfortable that I'm actually doing something useful, I'm not sure. If that helps. In my experience, it's interesting you said that people are resistant to using insulin in this setting. In my experience, pregnant women would do anything for a period of time if they think it's going to be helpful for outcomes. So the concern about using insulin, I have never encountered, well, never is a strong word, but it's certainly less manifest than if you're starting a 50-year-old on insulin for the first time, if that helps.
Dr. Vela, there is another question comes most of the time before us. Sometimes a female is using glargine or any insulin and she gets pregnant without any planning. Then after 4 weeks and she knows that she has got pregnancy, and 8 week is the time when organogenesis is there. Is it right to switch her to some safer choice of the insulin which is recommended in the pregnancy, or we can continue with the glargine? Because from both the sides there is a harm, because I think keeping her hyperglycemic is bigger harm than switching over to the then continuing with the glargine. What is your idea with this, and what is your opinion?
I agree. I actually don't normally switch. I mean, we discussed the fact that technically they are not they have not been proven, but generally I do not switch. And I mean, modern insulins actually provide safer. I mean, it's not dramatic, but they are better at preventing hypoglycemia and allowing better glycemic control without hypoglycemia most of the time. And if somebody has become comfortable with using a particular insulin, probably that is not the time to start changing.
I have a question, Dr. Vela.
Yes.
Are there any biomarkers, such as maybe serum adiponectin or vitamin D, which could be done in the first trimester and which could predict gestational diabetes in the third trimester?
Yeah, so excellent question, but unfortunately, no, there aren't. So in fact, we are contending right now, actually, that perhaps rather than doing a standard OGTT, at 24 weeks or 28 weeks, perhaps if we did an OGTT at 3 months, but instead of basing our decisions on glucose, we based our decisions on beta cell function measured with the minimal model, perhaps that might be a better predictor and allow us to intervene early than just using glucose-based measures of health, so to speak, because of all the limitations associated with that. Of course, this is all hand-waving because it hasn't actually been tested, but we are proposing to do that actually in the near short term.
And another question is about the frequency of monitoring in those who are on insulin, it's pretty much clear. But then those who are diet-treated gestational diabetics and are doing monitoring at home, how often should they be doing it and reporting it back to us?
Yeah, that's a great question. So, so that probably needs to be individualized depending on the stage of gestation and the degree of hyperglycemia that's being observed. I certainly don't suggest that people check both fasting and 2-hour postprandial. I generally go with fasting blood sugars because those are easier to standardize. And most of the time, I think we start with 4 times a day, breakfast, lunch, supper, and bedtime. And then depending on the first 2 weeks of monitoring, we can adapt accordingly and cut back.
And continuous glucose monitoring has a role, the CGM?
Well, so I have a strange relationship with continuous glucose monitoring. So continuous glucose monitoring is probably very useful in people with type 1 diabetes and people with marked hyperglycemia. In gestational diabetes, where glucose concentrations aren't particularly abnormal, especially during the night, the incidence of false positives, false lows, and hypoglycemia alarms tends to make me discourage their usage anyway. So I don't routinely recommend it.
Right.
If that helps.
Sure.
Most of the time in our country, we face a problem that gestational diabetes women, and they don't turn up after the 6 weeks after pregnancy is over. Then what do you do in your country so that they remain in touch with you, so that you may know whether they are converting to type 2 diabetes or not?
Yeah, well, so that's not a problem unique to you. I think so in actual fact, you could say, by the way, I should have said this early, that I am here under false pretenses, in the sense that I've never followed the gestational diabetes sphere all that much, but now I'm working with Dr. Egan, Aoife Egan, who worked with me for a year, and now I'm helping her develop her gestational diabetes program. And we've run a study where we specifically have been getting people back after gestational diabetes and studying them for 1 year. And in our experience, we're finding that they're okay showing up at 6 weeks. They don't come back at 6 months and 1 year. Well, they do, but it's a lot more difficult. And it's a lot more difficult because a 6-week-old baby is a lot easier to take care of than a 1-year-old, for example. I mean, that's one of the standard problems that we face when we're studying these people. But and it's interesting because there are actually abnormalities in alpha cell and beta cell function that clearly are persisting in the postpartum period. So there is data which suggests that beta cell function declines by 50% in 1 year after gestational diabetes. That's based on qualitative measures of beta cell function, like HOMA. We don't see that much of a decline, but clearly it is an active evolving problem in half of the patients with gestational diabetes. We still don't know how to define which half is the one that's accelerating or progressing and the one which isn't, or where it's resolving. But that is future work for Dr. Egan, I think.
If I may ask, what is the evidence now that we have regarding the usage of different drugs during lactation? If anti-diabetic medication is required during lactation, what would be the best thing to use and what is permissible?
Yeah, so sulfonylureas for sure are excreted in breast milk. Thiazolidinediones, they are lipid soluble. I would see no reason why they wouldn't be excreted And I'm not sure I would want a baby exposed to a PPAR gamma agonist at that age, for example. Things like SGLT2 inhibitors are probably okay, although I don't think they are the right medication to be using in that setting from a pathophysiology point of view to the mother. Metformin, I think there's a lot of data and a lot of safety data in that regard. That wouldn't concern me. But again, I'm a very conservative insulin type person in these settings.
Because they would have used insulin for all of those months, and then again during lactation, which could be a good 1 year. So that would be almost 1.5 years of using insulin.
Yeah. So there's actually another interesting nuance there in terms of lactation and its effects on glycemic control. So it seems that lactation actually improves glucose effectiveness and glucose clearance, and is associated itself with improved glucose metabolism. That's another area which is of interest and deserves further study, for sure.
Dr. Anuj, you have any more questions? I don't see any in the chat box.
Have you experienced any time midnight or early morning hypoglycemia in pregnant women? Most of the time we see that pregnant women may go up to the 55 of milligram per deciliter of glucose level. So have you experienced in your practice, and how do you handle these kinds of the situation?
Yeah, so we do experience it, and a lot of it is management of diabetes sometimes is actually managing the pharmacodynamics and pharmacokinetics of insulin most of the time. So those are situations where you might consider the timing of the insulin or perhaps a change in insulin. The only other complicating factor that I might bring up is CGMs. So CGMs are notorious for, at least notorious for me, because I have a significant hypoglycemia practice. So I see people with insulinomas, I see people with postprandial hypoglycemia after gastric bypass. And the kiss of death very often is that these people are given just continuous glucose monitors, and they come with asymptomatic low blood sugars during the night. Asymptomatic low blood sugars, proving that they're hypoglycemic. And there's a huge incidence of low blood sugars which are not hypoglycemia, that are detected as hypoglycemia by CGM. So that is one other diagnostic strategy to keep in mind as to whether this is true hypoglycemia or not. But obviously, understanding the timing of eating and the timing of insulin dosing is key to preventing future episodes of low blood sugars.
Can we take this message that we should not treat hypoglycemia until the patient is not symptomatic in pregnancy?
So no, that's not what I'm trying to say. What I'm trying to say is that we have to be suspicious of asymptomatic low blood sugars if that is the only manifestation of hypoglycemia when treating gestational patients with gestational diabetes. Certainly, a hypoglycemic episode an hour after eating, unless you've really overdosed on insulin, is going to be suspect upfront.
Yes.
Kind of.
Obviously, I can understand the tricky situation.
Exactly. It's these nuances. It's just the only thing I would caution is against blind acceptance of what a CGM is telling you overnight. That is perhaps the better message that I should be giving, if that helps.
Dr. Rita, do we have?
So thank you very much, Dr. Adrian Vella, for this very nice and stimulating talk on diabetes and pregnancy.